Welcome to the second episode of Addiction Doc, a podcast where we speak the simple truth about a much misrepresented and misunderstood field of medicine. Our host is Dr. Eric Troyer, a board-certified specialist in the field. If you or anyone you love is struggling with this terrible disease, this podcast is for you. Dr. Troyer is currently practicing in Landis, North Carolina, and can be reached at 704-855-2101. Or you can check out their website at troyermed.com. Let's step into this discussion and see what we can learn from Dr. Troyer himself. Okay, guys, here we are. We are at Addiction Doc Podcast number 2, and we are here with our good friend, Dr. Eric Troyer, and I'm kind of speaking with him a little bit about what we'd like to talk about today. And Eric, I think you've got some interesting stuff you want to share with the folks, so why don't you kind of tell us what you're thinking about today's episode?
Will do. First of all, introduce my partner in crime here, Keith Cannonberg. We've known each other for a long time, been friends for a long time, and he's probably integral in both my practice of medicine, but definitely in probably the person who I am. I've heard him say a lot of times that if you want to see what you're going to look like in a couple of years, just look at your friends today. Mm-hmm. And that tends to be the way ahead, which in the addiction world, unfortunately, tends to not always be the best.
That's true.
So
in the addiction world, for sure. Mm-hmm.
So today we're going to kind of overview the multiple drugs, and I said last time that we weren't going to go into a lot of presynaptic, postsynaptic, neurotransmitter, this, that, the other thing, but a basic knowledge of it is important to understand addiction, so we're going to get into a little bit. Mm-hmm. The cells inside of our brains look like basically octopi, octopuses, more than one octopus, and the arms on each one of the octopus actually touch another arm or a head of a different octopus, the different cells. And chemicals kind of come out of the end of their arm and then go to the next cell over and either rev it up or slow it down or have some sort of effect on it through the chemicals that it releases from its arm. Mm-hmm. Those chemicals then are taken back up into the arm so that they're not constantly bathing that next cell with those chemicals, or else eventually it would have no effect, which we'll also talk about. There are drugs that, first on that next cell over, there are places where those chemicals attach and work, and if they don't attach, then they have no effect. That's the only way they're going to have an effect. Is we all had the little game growing up where you had the little square and you had the little star and you had the little circle and you had to put the right piece into the right hole, or else you never finish the game. So if you think of the other end of that, the next cell over has a square, and you're trying to put a circle in there, it's not going to have any effect. But if you've got the square, which is what it's generally the body designed, a cell that releases squares is right next to a cell that receives squares, boom, it has the effect on that cell. It doesn't stay there forever though. Eventually the chemical breaks down, or a lot of times what happens is the cell that released the chemical takes it back up. Mm-hmm. And it just stores it until next time it's needed, next time it gets stimulated and needs to tell the next nerve something. So there are drugs that look like squares, and that's how they work. That would be marijuana and the opiates that actually look like the receptor. So when they get into your body, they go through the bloodstream, they hit those square receptors, and they actually hit that cell, that postsynaptic neuron, and cause it to get stimulated or knocked down more in the form of marijuana, but stimulated more in the form of the opiates, and then it leads off to do whatever it wants. And that's how.
Can I ask a clarifying question?
Certainly.
Okay, so the way I understand it is that the cells never touch.
No.
There's a gap.
There is.
And so the way I understand it is that's the synapse, is the gap. So the way I understand it is the one cell sends that chemical across the gap. Mm-hmm. And the chemical is what's shaped in such a way that the other side receives it. So you have sending and you have receiving, and then it's what it shoots across is the shape that tries to mirror this other side. Is that correct?
That is correct. The ones on this side that send it are the presynaptic neurons, the one on the other side that receive it are the postsynaptic neuron, with the synapse being between the two. So again, some of the drugs work in your body by just mimicking, pretending to be that chemical, and they immediately just stimulate that cell and a bunch of other cells, because they're all over the place inside of our brain. A whole lot of square cells inside of our brain that do that. Others, like the stimulants, cocaine, amphetamine, et cetera, don't actually hit necessarily the receptor. What they do is they keep this cell that released all those little square pieces out into the synapse. They keep that cell from taking those squares back into itself. So the other cell is constantly bathed now with all of these squares, whereas normally it might last for a couple seconds, maybe a minute, whatever, but now it's going to last for a long time. And it can actually even increase the release of those squares, so it kind of can work two ways. But that's how you kind of get that really large amount of chemical into the synapse, which really stimulates for strongly and for a longer period of time that next cell over. So that's again how the stimulants work. The problem with that is, and I tell the patients this pretty much every time I see them, is they don't give you squares. They just keep your body from bringing them back in, breaking them down, what have you. So those squares that you had in your storage now get depleted and depleted. And depleted.
So they cause you to produce them, but they don't make them.
They don't. They are not the squares themselves. So what happens is your body eventually breaks them down. You've essentially used all your squares that you had in that presynaptic neuron, that cell before. So now you got less. And here's the nice way I like to put it. Here's your energy level. And let's say you're having a bad day. So now it's down here. You take your stimulant, boom, your energy level goes up here because you just released all of those molecules into that cleft. And now everything's great. I've got all the energy I need. Problem is, they didn't give you those. It used your own body's energy producers to give you that up here. So now, since that's depleted, when you are off of it and it wears off, you're not here back to your baseline anymore. You're down here because you depleted your supply. So now you're really feeling bad, so you got to use again. Boom! Doesn't come quite as high because you've depleted the supply. And then when that wears off, again, you depleted more supply, so you don't even come back down to where you were. You're down here now. And over time, it gets to where you're just using the stimulant to even try to get back to where you started from.
Yeah, that's scary.
Yeah, and so when you decide to come off of them, you're just starting down here. And that next couple of days, weeks, whatever, as your body slowly builds it back up, it's going to stink. It just is. You're not going to have a lot of energy, and things just start going to feel good. You're not going to feel right. But on the positive side of that is you're no longer doing this as far as depleting your chemicals. Now you're going this way. You're slowly getting those chemicals back. Your body's building them back up because you're not overusing them and depleting them again. Okay. So it's a process. And unfortunately, there's not a lot of good medications to help people through that process. There, in fact, is no FDA-indicated medication for stimulant, for marijuana, for anything actually but opiates. Hopefully.
So would it be safe to say that illicit drug use, I guess that's the right word for it, it actually produces a mental condition, a mental deficiency?
It does, and that's why, as I mentioned in the last episode, you really can't say somebody's depressed, you can't say they're anxious, you can't make any real legitimate psychological diagnosis as long as they're using the drug. You have to wait until they come off of it and get back to their baseline, to their normal self, and then you can actually make a good determination, unless, again, as I said before, of course, they were depressed beforehand. If they were depressed beforehand, and that's why they were using the drug to try to self-medicate, to treat themselves.
So that's why it's so important to kind of gauge their body chemistry while they're going through recovery.
Right. And to see how things are going. And it's a constant. You don't just say, okay, here's your medicine, see them a month later, and say, hope everything goes well. Starting out, it needs to be very regular visits, weekly, for a while. especially while you're kind of getting them the psychological tools that they need to get the people out of their lives they have to get out of their lives.
Mm-hmm.
And I'll go ahead and touch on that now too as well. I get asked frequently, because this is true, why do the men in your practice do so much better than the women in your practice? And I said, well, that's an easy one. I don't have to think about that one. The men in my practice have a woman behind them, encouraging them, threatening them, telling them this is it, you better go back on track and do right, or I'm out of here. Whereas the women in my practice, unfortunately, not always, but probably 75% tend to be with men who bring them right back down to the addictive world, the mud I like to call it, because they made that choice to be with that person. Now, I won't say that is all necessarily a choice, because I do personally believe that you can be addicted to a person. And someone who's going to be addicted to a chemical, that's probably not a huge leap. It goes along with the other behavioral ones. The only one that's actually recognized by the psychiatric community is gambling. But we all know there's more than that. We all know that there's pornography and video games and other people.
Eating.
And some people shopping. And one lady who actually admitted that. Just different things, the behavioral ones, but the person, I don't know if it's even the person, it's the relationship. That's what they're addicted to, is being in the relationship. And unfortunately, a lot of times, especially with women, the more abusive that relationship is, the more addictive
it becomes.
Yeah.
It releases some type of endorphin, right? Whether that's a positive stimulant or a negative stimulant or whatever it might be, it's a stimulant, correct?
Correct. And my wife, after watching the episode, wanted me to bring this point out. And I'll take a quick aside there. By next week, we'll have on the website where you can throw in suggestions and questions. So please get in touch with us, because we can always use material. Got enough kind of set up here for
that would be very helpful
for several episodes. But she brought up that I really needed to bring out that back to this kind of thing with the amphetamine. So once you take that first dose of the medication or the drug, then your brain's not going to be quite the same again, especially if you're under 25, because your brain is still forming up to you're 25 years old. So that's when
I'm stuck with who I am now.
Probably.
That sucks.
Actually, people can change, and that's the other thing too. Is the other part of how these drugs become addictive and why you never get that high again, is those neurons that we were talking about. Once over time, this keeps happening over and over again. The cell on the other side says, okay, I'm getting too many squares. I'm going to take away the number of holes that I have for the squares. I'm going to downregulate. I'm going to take away some of those receptors. So now, instead of there being 100 receptors there, now there are only 50 receptors there. So you have a normal stimulate that comes along, happy, your child's getting married, you win the lottery, what have you. And normally you would release, the normal amount even after you've recovered for a period of time. You release them the normal amount, but because there are fewer receptors on this next cell, you're not going to get the same happiness. You're not going to get the same joy. You're not going to get the same bump in energy or whatever that you would normally have gotten before you started using the drugs. So that's what people chase, is even getting back to normal, and why depression and other psychological conditions are so prevalent, and why people just don't seem to kind of enjoy themselves, be themselves after, even through the recovery process, is because now they can come back. That's the good news, but it takes a good while for but your body's not just going to be content with constantly letting you do things. Your body does adapt. Unfortunately, people out there who might be trying to lose weight, you cut back on your calories, your body slows down your metabolic rate. Just doesn't seem right, doesn't seem fair, it's not right, but it takes fewer calories to do the same amount of things. So that's why people who lose weight, they have to keep cutting down and down and down on their calories. So, not meaning to be negative as far as you'll never be the same again. You'll be different, not necessarily worse, but different. So, but it is going to be different for you. And that's one of the very first questions I did ask people was, what does the word high, when you get high, what does that mean to you? What is that sensation? Is it happiness? Is it this? Is it that? And the most common answer I got, probably 75% of the time, was energy.
Yeah, I get that all the time.
Yeah.
It gives me energy.
Yeah. And that's what people chase, is that energy, because they've got the couple of kids running around, they've got the 3 things they have to do after work, and this and that and the other thing, and it just becomes. But where the lie comes in is all you're doing is depleting those chemicals, so you're never not only going to get the energy you had, but you're actually going to come back at a lower level. So that's the problem.
I have an interesting side note on that, just from my experience. And anytime I speak, folks, I don't know what I'm talking about, so I defer to him, but I just observe. And so my observation is, I hear people all the time. They'll talk about, pain pills, things like that, and they say they'll take these pain pills, and you're right, every single time it's for energy, it's for energy, it's for energy. I personally, my experience, when in the past I've had any kind of pain medication that's been given to me, it totally knocks me out. I'm like, how in the world do you get energy from pain pills? I'm out for like 12 hours. I mean, the last thing in the world I want is pain medicine. But boy, you give me a cup of coffee, you give me a Red Bull, you give me, a couple sun drops, and I'm feeling good. Right? So can you explain why that's different?
That's the genetics that we talked about last time, how a lot of this is genetic, and you're born with it. You're born with the genes and the genetics that make opioids to you snooze you out. Other people have wired completely different. Their response to that chemical hitting that receptor is completely different. Instead of maybe lowering the amount of the energy chemical that gets released, it actually raises it. And that's, again, just genetically. Some people have blue eyes, some people have brown eyes, some people are a lot taller than me, some people are my height.
So therefore, you're going to have people that are going to have preferences toward the illegal drugs.
Absolutely.
Some people are going to be more, they're going to be more preferenced towards stimulants, and other ones are going to be more preferenced towards opiates.
And that's why trying to get people to understand somebody else, especially family members, which we're going to really get into here in a second, to understand somebody else, as you may be wired one way, but they are wired completely differently. And unless you can take a step out of yourself and realize that, but also realize that you've got your own thing too. I believe everybody's got their thing, and that could actually destroy them, take everything that they have, and lead them to a very bad and dark place that sits inside of each one of us. I believe it's there for a reason. My religious beliefs caused me to believe that it was allowed to be there so that we would need the right thing to put into that hole inside of us, if you will.
It's kind of chasing, you're kind of constantly chasing a center. You're chasing something bigger than you are.
But again, if everybody's honest with themselves, they'll admit that, yes, I've got my thing too. And if I indulged in my thing, be it gambling or whatever, then I would be just like my cousin is, or my daughter is, or my husband is, who's going through the addictive process and the addiction that they are going through, most likely chemical, because that's the one that tends to get the most attention, because it it's much more common, and it usually leads to a lot more serious medical and relationship and even financial effects on people. So, bringing that back to my bio, I'm going to talk about my favorite subject in the whole world, and that's me. So, coming back to that part, I have experienced addiction. And some people may say, oh, that was a cop-out. You just did what you wanted to do. And that's what people tell other people who are addicted. And that's, again, if you can't understand and can't be in their shoes and can't understand that, then probably going to be a lot of help in them in the recovery process. But mine was a person. And it met all the criteria as far as compulsions, continuing despite negative consequences, cravings, constantly thinking about it, losing control, and just not being yourself. I mean, not being the person who you've been your entire life up to that point. And as a result of that, I ended up losing everything, living in my office for a while. And I was going through some stuff, and now we're moving on into the family member part of it, or the friend part of it. I had a friend who one day said to me, "Eric, you're being a jerk." And they were right. I don't know why. I don't necessarily recommend that if you're trying to get somebody who you love or care about to change what they're doing and to get out of their situation. But that hit home for me. And I was able to step back enough to say, wow, I am being a jerk. I'm being a self-centered jerk. What can I do about that? And I'll go ahead and go into the first chapter of the book I wrote next. So, Jean-Luc, or Jean-Luc Picard we'll call him, is a starship captain. Great guy.
Would you call him Jean-Luc Picard?
Jean-Luc Picard. Star Trek fans will get that. There's an episode where that happens. And I need to use the word Gene. So, he's a starship captain, great guy, always wins the day at the end of the episode. But he, as we talked about in the last episode, gets hijacked. His brain gets hijacked by an evil organization called the Borg. They take over his will. He no longer is able to control his own body. He still is in there. He can remember things, and he's aware of what's going on. And in fact, the Borg use his knowledge and his experience against his friends and the ones that the Borg are trying to destroy and conquer and work against. So, they take him over. He's now under their control, and he's doing what they want him to do, and he's kind of helping them fight his former, current still, friends and family and co-workers and all of that. So eventually, the friend's family just give up on him and say, the heck with this, we're going to blow up that ship with him on it. So, fire. And then 3 months later, after the summer break, you come back and you find out that the firing didn't work. So it continues, the fighting continues, and eventually he is able to break away from the Borg. And then at that point in time, his friends and family and co-workers are able to use the knowledge that he's gained from that experience to defeat the Borg. And even though now he's back to kind of his old self, there's still scars, physical and emotional, that follow him for the rest of his life from having gone through that experience. Now next is an amalgamation of what I've heard from a lot of patients. It's not one specific person, it's just kind of a whole bunch of people put together. Jean Marie, 40-year-old lady, married to Tom, who's a construction business owner, doing well. She does all of his accounting and book work. Tom was kind of an adventurous spirit, so he decides one weekend to set up a zip line in his backyard because he's got some nice hills and stuff. And so he tries it out a couple times. Things go great. Thinks he's got everything secured, so he talks Marie into doing it. So Marie gets on the zip line, and unfortunately, about halfway down, the line comes unhooked from the tree it's attached to, and boom, from about 7 feet in the air, she lands flat on her back, breaks 7 ribs. Goes to the emergency room. They give her some oxycodone for a few days to kind of help her with the pain, and they'll tell her to follow up with her regular family doctor. So she starts taking the oxycodone. She feels pretty good. She gets that little energy boost, even though she's still hurting a good bit. When she goes back to see her family doctor a few days later, the medicine seems to be working pretty well. So she tells him that, and he continues the same medicine, same dose for another week or two. At the end of a couple of weeks, still hurting some, still liking the way the medicine feels, but she actually wanted to try one day to see if she could come off of it. And about 7 or 8 hours after taking that last dose, she doesn't feel so good. Maybe a little queasy, maybe a little achy. So she takes some medicine, that all goes away. So okay, good. I'm still hurting anyway, so I still need to take this medicine. So a couple weeks later, she goes back to her doctor, gets another prescription for a month at that point in time, because it takes ribs a little while to heal, and he can't I wish we had this painometer. We could put a painometer right here on somebody's forehead, and we could actually see that pain scale inside somebody. Anybody out there who's really inventive, come up with that, please. We could really use that.
To track true pain.
Yeah, true pain.
Yeah.
Or emotional pain would be probably helpful too, honestly. But yeah, physical pain. So, she gets a prescription for the next month, and by the end of that time, her pain's gone. Ribs healed, everything's great. But again, she tried to go without the pain medicine for a little while, and it was not fun. Not a pleasant experience at all. And she'll still get some energy from taking the pills. So she keeps going back to the doctor monthly after monthly, and the doctor eventually realizes, I've been giving you these medicines for 6 months now. This rib is healed, so we need to stop it. She said, no, I'm still hurting. So he refers her to a pain management center. And they're backed up 3 months, so she happens to hear from another person that she knows about another pain management center, and they just take cash. And they can take insurance, so she goes there, and they're write a prescription out for basically whatever she wants. Not only they put her on the main medicine, but they throw a little Adderall and a couple of Xanax in there as well, just because she gets anxious from time to time, and she had ADHD when she was 8 years old. So now she's on all 3 of these medicines, and things are going along okay. She's having to pay a couple $100 a month, but the business is able to support that. And then the pain clinic, she goes there one day, and there's a sign on the door that says closed. If you need your medical records, have your physician contact us at this email address. And she said, oh my gosh, what am I going to do? Because by now she is deeply hooked on definitely the opioids, maybe a little bit on the other 2, but mostly the opioids. So she's standing there just in a panic, and all of a sudden another lady walks up, looks at the door, says, oh, doggone it. There's a second one that's closed on me like this. Thank goodness I have a backup supply. And then she starts to walk off, and Jean says, no, wait. Who's your backup supply? I desperately need to get these medicines. And it's okay, and her name, we'll just call her Susan, gives Jean the number and the contact information, and says, well, I'll call them, because if somebody just calls them out of the blue, they're not going to get in touch with them, but I'll call them and let them know your situation. So she gets hooked up with the dealer, and she is paying a lot more than she was paying at the pill mill's office. So now she's running through thousands of dollars a month, and she's depleted everything. She's pawned everything she can pawn. She's starting to take money out of the construction business. Eventually, Tom catches on to what's going on, and asks her what's going on, and she says, you're the reason I'm in this mix. You need to help me out, because you put out that stupid zip line, and it's your fault that I got a broken rib, and now I'm hooked on these medicines. So Tom...
It's your fault. It's the doctor's fault. It's the system's fault.
It's somebody else's fault.
Yeah.
So now Tom does feel guilty, so he keeps floating her along until it gets to the point where it just becomes cost prohibitive, and says, no, that's it. You're going to get off this stuff. And so Jean goes to the dealer and says, please, I gotta have this stuff. Can you just give me a break on the price or something? He said, no, I can't, but heroin's a whole lot cheaper. So she starts doing that. And she starts snorting it initially, but then she moves on to shooting it. And along with her friend Susan and some other people that Susan knows, and contracts hepatitis C. And unfortunately, it's one of those 2 or 3% of the strains that the medications don't cover and don't treat. So her medical condition starts going down there. So after 2 years and 3 relapses later, Tom's had enough, and he's out. He kicks her out and says, that's it. You're gone. So she lives on the street for a while and is staying with people and doing what she can to survive. And then one day, she wakes up tired of it. She's just tired of it. She doesn't want to live this life anymore. She doesn't want to be this person anymore. And I wish, family members, friends, I could tell you that there's something magical you could say, like you're being a jerk, or something magical you could do to make that happen. But that was one of my questions with my patients is, was there something that somebody else said? Was there something that somebody else did? Was there something that somebody else, brought into your life that allowed you or motivated you to get clean? And 80% of the time, the answer was no. I don't necessarily believe that, because when I talk to them about something else, about who do they admire the most, who would they most like to be like, it's almost always the person who didn't abandon them during this whole process. So if you put those two together, you kind of come up with the answer may just be being there, and being there at the right time to say the right thing, which you may have no idea is the right thing, but just being there.
Can I throw something in there?
Please.
So I totally appreciate that. I think that's some of the history that I hear over and over and over again with people. Sounds very familiar with Jean Marie's situation. I think that they get to that point when they've lost everything, right? When there's nowhere else to turn. And they're like, I've got to do something. I've got to stop this. I've got to get away from this drug. I personally think they hit a rock bottom. They hit a low point where there's nowhere else to go. You know, your situation with that particular thing, you hit, believe it or not, for you, that was a rock bottom. Somebody that you respected, somebody that you cared about, making an observation of your life.
Kim, by the way.
but the point is that somebody made an observation of your life,
right?
And you're like, oh, that's not me, right? And then you just you turn that around. You're at the point you've got to do something. You've got to get away from this particular thing. The thing that I think is so interesting, and the thing that I'd like to really stress here, is that if you care for somebody, you can't enable them. And when I mean enabling them, if you're constantly throwing that net up underneath them, right? If people kept on coming and going, no, you're awesome, dude. You know, you just keep on being you. We love you, right? You throw the net up underneath you, you never figure out you're a jerk.
Right.
Right? And if you never figure out you're a jerk, you're safe.
Right.
Sometimes it's your family, sometimes it's your friends, sometimes it's your finances, whatever it is. Everybody's priorities are different. I think we're going to talk a little bit about that. It's when you hit rock bottom. And I think one of the biggest, most traumatic things you can do for your loved one is to stop them from hitting rock bottom, because they need rock bottom. And if you are dealing with like a teenager or whatever, rock bottom from 18 years old, from 17 years old, is not that far down. But if you keep on throwing that safety net underneath them, next thing you know, they're 25, they're 30, they're 40, they're 50 years old. Rock bottom from 50 is a long honking way down.
Yep.
Right? Does that make sense? Am I?
Oh, absolutely. And that's the fine line between being there and enabling. Enabling is providing an environment or resources that allow them to continue doing what they're doing. Being there is not necessarily putting up with what they're doing, but it's just making sure, touching base. Do not cut off contact.
It's not rescuing.
No. But it's just kind of being available, talking. That's probably the biggest thing. It's just talking. So
tell them you believe
face to face, or but don't provide them any resources that will help them continue in what they're doing, or they will continue in what they're doing indefinitely. And it would be, again, nice to say, okay, everyone I asked said they had chicken pot pie to eat the night before. So go out and get your loved one a chicken pot pie, and the next morning they're going to wake up and not want to do the drugs anymore. But there was absolutely none that said, I had to be ready. I did this for myself. I had to be, I just wasn't ready before. But it had to be for me. And again, I don't know what it is that makes people come to that aha moment.
I have never heard one single person in all the years I've been doing counseling for you. I have never ever heard one person say, you know what got me straightened out was my mom loved me so much, and she told me I needed to stop. Yeah. And she told me I just needed to quit. And she went and she was always there for me to make sure I always had money and make sure I always had resources. And she came and she paid for me to go to rehab over and over and over again. And she kept on taking me places I didn't want to go. And she kept on putting me in all these places. I've never heard anybody say that's what got them off from drugs. It's always been, I was tired. I was done. I had it. I had hit rock bottom.
Yeah. Now, with women malpractice, a lot of times it is something to do related to their children. If it gets to the point where they are losing or about to lose their kids, a lot of times that is enough motivation. For some people, it's going to jail. For some people, it's not. But again, 20% of the time, it is something that is a threat or that is a negative consequence, that if they continue to use, this is what's going to happen, then it is actually not enough to motivate them to stop using. But the 80%ers, just stay with them. Don't enable them. Don't provide them with resources that they could use to then turn around and sell.
Let them know you believe in them.
Yeah, let them know that you love the person that they are. You love the person that they were, but the person they were was a person that was a lot more productive, had a lot more relationships, a lot more money, a lot more independence, a lot more everything.
Help them to understand the resources they need are within them and not within your pocketbook.
Yeah.
Right? It's their resource, that the only resource that's going to help them get off the drugs is inside of them. Right? It's in the identity of who they are. It's in the value of who they are. It's in what's central to their life. And that's important for them to understand.
Yeah. Only one time in all the years I've been doing this have I said something that got people, a person, clean for a while. And that was, congratulations, you are actively 100% currently my worst patient. You've not made counseling, you're failing all your drug screens, you win. If I was giving out a prize like I do for doing well, for not doing well and for being the worst patient, you would be the winner this time, right now. And for some reason, kind of like the jerk thing, that hit them. So it doesn't always have to be, warm, I love you,
warm and fuzzy.
Yeah. Sometimes it can be the truth, the stark truth that they need to hear at that particular time.
And Eric, there's a school of psychology that's all about that. It's called Gestalt theory, and it's basically just shocking them. It's like psychological shock treatment. So I think there's some science behind that too.
Right.
Yeah.
All right. We'll start moving on from that. Although, I do want to come back to the two stories, the two genes. What do they have in common? What do those two people have in common? Number one is they were living productive lives beforehand. Everything was going on nicely, going on well. They got exposed to something, and I've heard the argument both ways. Well, just don't do it, don't start it, which is a legitimate argument. I will never argue with just don't start it. But I would dare say 90% of our kids do not leave high school without trying using some sort of drug, and probably middle schoolers even, unfortunately, these days. So the thought that they're not going to be exposed to it, and then you bring in the whole, it seems to be 50-50. About 50% of my patients start recreational. About 50% actually start with a prescription. So that's why a lot of the prescription writing has gone down on that, or it's very limited, but still, if they've got the gene that instead of knocking them down, revs them up whenever they get the opioid, unless they're a very strong person, then it's going to lead to other things as well, or continued on with the opioid use. But they were both productive people. They both kind of something that took over their wheels. They both eventually got to the point where their families and friends gave up on them and said, I'm done. I'm out. You want to do this, you're on your own, kind of thing, or fire, we're going to blow you up. But then it got to the point, too, where they were restored back. They decided one day, or were able to escape. That's probably a better analogy. They were actually able to escape this thing that was holding them captive, because it's a strong influence on the people who are addicted. I mean, it's uncontrolled. That's again, loss of control is one of the definitions of this. So they were able to escape that, and then after they were able to escape, they were actually able to use what they went through and what they learned during the process to potentially help others or help themselves, which a lot of people who I get through recovery or well into recovery are almost all interested in becoming substance abuse counselors or working with substance abuse in some fashion or form because they've been there. And as we also discussed, it's the community. It's sharing of the stories. It's not necessarily what you say to somebody. It's just the knowing you're not alone. Knowing you're not the only person who's been through this. That is important to the recovery process. Drugs in the community, the weekly update, if you will, as far as what's going on. Meth, fentanyl, still real high. I thought, rather than necessarily dealing today with the results, because nothing new, is a couple of ways on how we catch people. Sometimes we catch people because the urine they've got hidden in their body just pops and leaks all over our chairs. That's one of the more obvious ways. That's one of the more obvious ways that we catch people. We check the temperature on the urines. Most reputable places will be doing all of these things. I'm going quick aside on reputability. If you're looking for somewhere to get treatment, don't go somewhere with 5 stars. That's going to be the place that Gene went. And you get your month worth of buprenorphine up 6 a day, which maximum is supposed to be 3 or 4 a day.
Don't go somewhere with 5 stars. What do you mean by that?
On the reviews, because those are the places that give you that. Again, they'll give you your 6 buprenorphine. You come back monthly. You pay them $200. You'll get your Adderall and your Xanax or whatever else you ask for.
So addicted people who are trying to get a fix love the places.
5 stars.
5 stars.
Sweet spot's probably about 3 stars. Because that way you're going to catch some people who legitimately got better, and the people who came in who wanted all this stuff and didn't get it, it's going to give you 1 star, and the people who are doing well and doing what's supposed to give you 5 stars. So probably
every
averaging
once
out
in
3
a while,
stars.
if you're doing a good job, every so often somebody's going to be really mad that you didn't give them the drugs that they wanted.
Yeah.
And that's going to show up in your reviews, and it's going to show up in your comments, and it's going to show up in your feed. So I think that's really important to understand.
Yes. So then, again, reputable places will be checking urine drug screens when you come in. A couple things we check on that to verify that it's a valid sample, because what will happen a lot of times is people obviously bring in outside urine, sometimes from a kid, sometimes from a friend, sometimes they buy it. It's an interesting, apparently there's a market out there, but unfortunately for them, several times when they bought the urine, it's actually had drugs in it. But there are other ways to tell whether it's legitimately theirs or not. We check the temperature. Sometimes it's 70 degrees when it should be a lot higher than that. Sometimes it's 104 degrees, which they're not passed out from a hyperthermic coma, so there's no way that's their urine either. They put that in a microwave to try to fool us. And then we check out different things to make sure it's actually urine. So it's a chemical called creatinine, which is supposed to be in urine. If it's not there, then it's not urine. And then we check for metabolites, as well as the other meds they're supposed to be taking. I've had people come back, because we actually check for nicotine too. I love checking for that one, because 90% of my patients smoke or use some sort of nicotine. And so if they say, I asked them earlier in the interview, yeah, I'm still smoking a pack a day. And yet I look at the last 2 urines, which have been clean, and there's no nicotine in the urines. Okay, that's not your urine, because the nicotine hangs around there for a week or more. Or the other medications they're supposed to be taking that you're prescribing. Those medicines aren't in there, but yet this other medicines you're not supposed to be taking is in there, so probably not your urine.
So you could check for pregnancy too, and if Ralph comes back that's pregnant,
well,
we probably got an issue.
We normally don't do the pregnancy test. But the other thing, the big one is metabolites, which is why sending the urine test out is an important thing. Buprenorphine, or a lot of other drugs, for instance, break down into something else in your body. Hydrocodone breaks into 2 different things. Oxycodone breaks down into 2 other things. So we check not only for the oxycodone or the buprenorphine or whatever, but we also check for the metabolites. So let's say they're supposed to be taking the buprenorphine, and the level comes back at 1,000. But those metabolite levels of norbuprenorphine comes back at 0. That means that buprenorphine did not go through their body. It was dropped right into that urine sample. Probably a urine sample that had nothing else in it. Probably, who knows where it came from. So there are multiple ways, and I tell people this their first visit, is lying is part of using. It just is. Lying to yourself, lying to your family, lying to your friends, lying to whoever it is that you have to lie to keep this lifestyle going or secret or what have you. Part of getting clean is coming clean or telling the truth. And that's a very difficult thing to do. It's a lot easier to remember, fortunately, but it's a very difficult thing to start doing after lying for so long.
A lot of times when we're sitting in group sessions and we have people sharing, and you'll get a new person that's in there and they're talking about their situation, and they'll say, yeah, I kind of slipped up or something other. All the other patients, all the rest of them say, whatever you do, don't lie to Dr. Troyer, right? Tell them the truth. Tell them the truth, right? Why is that?
Because, what I also tell them the first visit is, let's use this time productively. Figure out, if you mess up, you mess up. Part of the hallmark of addiction, unfortunately, is relapse. It's just a reality. And that's why I have a hard time accepting myself personally, because I do take a lot of time just personally. Because I feel like I'm in a battle against drugs out there, and I like winning. But I just tell them, let's actually spend this time talking about how it happened, why it happened, and how to keep it from happening again. Rather than, oh, no, everything's great, rainbows, unicorns, everything was great this week, didn't use it all. Get the urine back, not so much. And now I can't trust what you tell me anymore. Now I have to trust the urines, and there have to be a whole lot more of them. So we'll see you a whole lot more frequently, get a lot more testing done, and I'll trust the urine test and not necessarily what you tell me for a while. Now, your trust can be restored to a certain extent, but you'll trust but verify. So.
And they're also in a dangerous place if they use while they're taking Suboxone as well, right? I mean, like after they've been off from the drug for a while, and they're using Suboxone, their body's tendency to absorb or whatever the drug of choice, now all of a sudden that limit goes down, and what they used to do in order to get a certain high, now all of a sudden it affects them differently, and there's a much increased chance of them overdosing.
Well, yes and no. Yes, while taking the buprenorphines because it's just a Parkinson agonist, yes, you could take enough, potentially, and there'd be a whole lot you might not even afford it, of other drug to overwhelm the
blocker.
The blocker. Doesn't happen a lot, if any, ever. But for people who decide they want to use, now if they stop the buprenorphine for a few days, let it get out of their system, and then they go to use. Then use, yes. And that's what I see. So most people, almost everybody comes out of jail. It's a dying of an overdose, especially if they go right back to using, because they go back to using what they were doing before they went into jail. Their body have built all those little postsynaptic receptors, all those squares are back. And as opposed to only having half the number of squares, now you got all those squares, so use that amount, hits all those squares at one time, you stop breathing and you die. So yeah, that on that side of things, absolutely. If you've not been using anything for a while, including buprenorphine. But I've seen probably, the nice thing about buprenorphine too is I've probably seen it save many people's lives, because they've come in with fentanyl levels that they would probably be dead in the urine if they didn't have that blocker on there, more or less protecting them by not letting all that fentanyl hit all those receptors at one time. The blocker has a higher affinity for the receptor. In other words, the receptor likes it better, and it'll hold on to it. He'll hold on to it as opposed to going over here and getting the same thing. Unfortunately, buprenorphine has a real high affinity for the receptor. Yeah, for the receptor. So the receptors really like to hold on to it, because if it wasn't in there, they'd probably not be here still.
They'd blow up.
Yeah. So we do all those things, and bring up there are 2 drugs, because the third way we catch people is just by how they're acting. They're not acting like themselves, and some of them realize it, but there are 2 drugs that people are convinced 100% that they're getting away with it and nobody can tell. They're their normal self. I mean, I've got this. Nobody can tell. I'm cruising. Nobody's going to know anything that I've done. And it's alcohol and it's methamphetamine. And what's interesting about those two is they're the most obvious. The person is impaired on those two drugs. So it's a nice contradiction there as far as that's the third movie catch people, because the staff usually comes in, before I even go in the room and say, wow. So I'm sure that's happened in counseling sessions, because people who have been addicted before, if somebody else comes in, that guy, a lot of times after the fact, I imagine you hear it during, I'll have 3 or 4 people come in the next day and say, well, I don't know what his name was, but that guy was high yesterday when he came into the counseling session. So you just can really tell.
The white powder under their nose is generally
that's
a good
it,
giveaway. No, just kidding.
That would be it.
It doesn't.
Last thing I'll touch about today is Let's Do This, our logo, if you will. I made a movie many years ago with Meatloaf, Ed Asner, and Furlong, and a couple others, and had an assistant director who more or less acted like the director, in my opinion. Before every scene, everything would get set up, and right before the scene would start, he'd say, okay, in his Italian accent, let's do this. And that's kind of what we're doing here. It's a call to action, both to get clean if it's you, or to do what you can to help those around you, which, maybe just be insulting them, maybe pointing something out to them, maybe just being there without enabling them, to allow them to move forward and to get help and to get recovery. Mm-hmm. So with that, we'll wrap up this episode. Next episode, probably turn things on Keith and interview him as far as his experiences in this field. And again, by next time, hopefully we'll have set up where you can submit your questions. And until then, hope everybody has a great day.
Okay. Let's do this.
Let's do this.
We'll see you guys.